Good evening, everybody. Welcome. I've lost my voice today, so I don't know why, but as Stephanie will tell you, my palliative care person, and Janelle, a patient, this is just one of those nasty side effects of common with this. Just decided to appear 2 hours ago. So I apologize for that. This is a panel that we're doing that's a little bit different. We don't have doctors on it. We're not talking about cancer or drugs or progression or pain management, but we're talking about really a critically important subject, and that is advocacy. And hopefully at the end of this conversation, the end of the hour today, you'll have a greater appreciation that advocacy, either as a patient, either as a caregiver, or external advocacy, which Brian's going to talk a lot about, are critical to our journey. And one of my takeaways, I love to have takeaways, is if there's one thing that you take away from this conversation, is that there are things you should be doing with respect to advocating either internally or externally that you're not doing, or if you're doing everything, kudos to all of you. Before we get into the substance, I thought I'd have each of the panelists just briefly tell us a little bit about them. And I will start with my friend Janelle.
All right. My name is Janelle Reese, and I was diagnosed with stage 3 kidney cancer in 2022, so 4 years ago. And then a year and a half ago, I progressed to stage 4. So I've been mostly in the battle in those last 18 months. I do still work full time. I am a global EHS director for a global company, and I still travel when most of the time I've only had to cancel one trip, which is next week, but it happens. And then I have my husband, Kevin, who may be on the line as my amazing caregiver. And I have 4 grown children, and they're just delightful adults that are living a good life.
Welcome, Janelle. And Janelle's, I tell my story. I was at Chicago taking the last trip to Denver to speak at the KCA meeting. My flight was delayed 4 hours, and Janelle was in a totally different gate going to Europe, and she walked all the way down. I didn't know she had a walking issue. So here I am with my little cane, but she walked all the way down to give me a hug. And you've done that a lot, Janelle, with lots of different people. So I think you win the award for that. So thank you. My friend Michelle.
Hello, everybody. Brief introductory for those who do not know me or see me on calls. I was born and raised in Illinois, outside of Chicago, relocated to Florida about 8 or 9 years ago. My professional background is in information technology across sectors of financial, pharmaceutical, and health insurance in the consulting roles most recently. I was a stage 1 clear cell renal cell carcinoma person, incidentally found in 2020. Thought I was good to go, only to be found in 2024, metastasized to my pancreas, which now I am a stage 4 person with a couple of bone mets as well. I'm currently I was on Opdivo Yervoy, now I'm on monotherapy Opdivo since February of 2025, and had SBRT radiation to the bone mets. All is good. I'm considered ogliometastatic or oglioprogression for this little bit of growth in my pancreas. And I'm trying my dangest to stay on my first line of treatment as long as I possibly can. So I'm glad to be here.
And what do? We fight the side effects and stay with the meds when we can, right?
Absolutely, we do.
Because some of us here feel like doctors give up that's working, at least it was as of last scans, to deal with the side effects, which, by the way, I'm in that scenario right now. I'm dealing with shitty side effects. Stephanie's obviously not doing her job, but I'll get to her in a second. It's going to make Stephanie smile. Let's go to Brian next.
Yeah, hi everybody. Brian Lewis. I'm located in Philadelphia. I was diagnosed in 2007 and was fortunate enough to be picked up by the NIH and taken care of surgically there, and have been NED for almost 10 years now. And I am the CEO of KidneyCAN, which we'll talk about later in the show.
Thank you, Brian. And we love those success stories. And I am watching the clock very carefully because this is supposed to be around an hour. So we will save at least 10 minutes for Brian to talk about KidneyCAN, because that's external advocacy, which is another critical topic. I have now had my second Northwestern palliative care speaker, because I probably talk to them every day. I'm surprised Stephanie accepted this invitation to speak today, because we talk almost every day. Stephanie, would love to explain your role and what you're doing here today.
Sure. Like Joel shared, I'm a nurse practitioner with a palliative care team at Lake Forest Hospital, which is a Hospital Division of Northwestern. So obviously in the Chicago suburbs. And I've been there about 6 years now. And I, outside of work, have a 1-year-old that keeps me very busy and a 12-year-old dog. And yeah, just really love the work I do, love getting to know people. So that's all for me.
And I'm glad you didn't say that I keep you busy because I know I do. But at least I do non-urgent emails. So I'm proud of, or non-urgent my chart. Stephanie and her team and Martha, but primarily Stephanie, just take care of all the, I always say doctors are great at treating the cancer. They're not great at treating the ancillary issues like nutrition, pain management, side effects. And Stephanie's helping me throughout all that. So thank you very much for joining us today. I always like to share objectives, and you guys are the judge of that. And but by the way, Linda pointed out something very important on the chat. First of all, thank you, Judy Nicholson Foundation, for sponsoring this panel. But secondly, this event is being sponsored by Merck, BMS, and Exelixis. So thank you to all of them. And we count on them, and they're just absolutely amazing to us. So thank you. And obviously, we count on the Judy Nicholson Foundation. So the objectives today are first to understand what advocacy is in dealing with the RCC journey and arguably understand what it isn't. Second, and this is Joel talking, and I'll be interested in Stephanie's comments later, but my opinion is that advocacy can be the difference between a lengthy overall survival or a short overall survival. And it's one of the areas that's not given the level of attention that it should, but good advocacy, whether that's the patient or the caregiver, is absolutely incredible. We see a lot of people in our Facebook communities talk about faith and talk about their doctors, and all that's critically important. And I don't mean to minimize it, but you have to grab the bull by the horns. You have to advocate for yourself or have a loved one advocate for you. As I look at Kathy and Tom as a perfect example, where Kathy does an amazing job of advocating for Tom, so maybe she'll weigh in. But that's very important. Another objective is to understand how you can advocate externally for more funds to help with the RCC research. And Brian's going to be speaking to that in detail. And then my goal is always to provide you with at least one takeaway, something that you think about and act upon that you wouldn't have but for attending this meeting. You are all a very important part of this panel. So you can ask questions by raising your hand or putting questions in the chat line. We will do our best to answer them as they come through. We want to answer your questions because really this session is for you. So the first thing I wanted to raise is, what is advocacy? What does it mean? And it probably means different things to different people. Janelle, I'd love for you to talk about internal advocacy and what it means to you. And then Brian, briefly weigh in on what external advocacy is, just to have the dichotomy of what the two are. Janelle, just at a high level, what does advocacy mean to you from the patient caregiver level?
So I'm going to give me a minute. I'm going to do an example that to me is a mental model that talks about what we're trying to do with advocacy. So everybody has a dishwasher at home, right? You have a dishwasher, and that is a way to automate a system such that you can free up time to do other things. Every caregiver or every care team that we have, so our oncologists, our insurance companies, they all have those systems as well. And one of the things that y'all would recognize from a dishwasher is that it handles about 90% of your dishes, but there are always things that don't fit into that system. There's cast iron pans, there's crock pots, and they don't fit in the system. So 10% of those have to be managed a different way. And so to me, we are that 10% of the dishes. We're the ones that don't fit into the automated system because we're not the typical, or we're not the 90% of patients. And so to me, advocacy is, you're not being high maintenance by advocating for yourself and moving yourself through the system. You're just doing the work that the system doesn't do well for us because we don't fit into the system.
That's a really interesting analogy. So thank you for that. And then Brian, just briefly again, and we'll go to you later, weigh in and talk a little bit about what is external advocacy.
Sure. I think simply stated, it's having our voice heard as a community collectively. And we have a saying in DC that if you don't have a seat at the table, you might be on the menu. And I think that's the way, because our Constitution allows us to petition our government, we're allowed as citizens to go and talk to our elected representatives. We're unique to a lot of people in the rest of the world. And we were taking advantage of that and going up to Capitol Hill and meeting with our elected representatives and telling them what we need. Kidney cancer has been underfunded historically for years, and we're trying to play catch up.
So what I like about the two answers to these questions is that's a great dichotomy between what internal and external is. What we're first going to talk about is internal advocacy. And Kathy, I just like to respond to chats. You're right. Since the federal government has cut funding, what Brian and his organization does is even more important. And one thing I want to ask Brian and Janelle to make a plea for at the end is more of us participating in what Brian's organization does. And by the way, that's including me. I say no to some things just because I'm doing so much, but it's such an important topic. I think it's one that everybody should raise their hand and do something to. And I'm going to let Brian make his sales call later because I think it's important. What I want to do now is really talk about internal advocating. I'll start first because it's important to understand my view of internal advocacy changed significantly, probably 15, 16 months into it. So I always said that you have to have a captain of the ship, because if you don't have a captain of the ship, then who's running the show? And you have a bunch of people. Like, I was just hospitalized in November, and it was hard for me to tell. I had hospitalists, I had GI doctors, I had so many different doctors, and it was very hard to tell who was running the show. Now, today I figured that out. I am the captain of the ship. But 8 months ago or 12 months ago, I would have said that the captain of the ship is my oncologist, and it is up to him to make sure that he is advocating for me, running the show, answering all questions, reconciling all issues that need to be reconciled. But one of my views, and it's been an epiphany for me, is that everybody here needs to take it upon us to be your own best advocate. And that can be caregiver too, it doesn't matter. But you can't just trust the doctors to know everything. They have several different patients. They don't know us more than we know us. It is just absolutely critical that we take ownership over the fact that we are the only people that can be the captain of the ship. And that's just an epiphany for me, but I think that's important to mention. Nobody cares more about us than us or our caregivers. And again, going back to faith or trusting my doctors and all, that's really important. And you should keep that if you have that, but you must take it upon you guys to take hold of your diagnosis and everything that's going on, and do the charting and keep track of everything that's going on and make sure that it's done appropriately and question when it isn't. So that's my view of internal advocacy. It's I own, the buck stops with me, and I rarely blame anybody else for things getting screwed up except for me, and that does happen. Michelle, love to hear about your view of advocating, especially with medical teams across disciplines, because that gets to be very difficult. And even across, we'll let Janelle talk about that, but just across disciplines within the hospital. What's your view of that? How easy is it to tackle? What are some tips you have for that?
Oh, okay. Yeah. So across the medical team and across the hospital, some of those are different beasts in of themselves. But when I think of advocacy, I think of it as this, what you start in advocacy is may not where you end up, because it changes along the continuum. So when you get diagnosed with the disease, you're in a panic mode. What do I do? You don't even know where to turn. After you're seasoned a bit, many of us on here know and can help others. So I think back to my days of when I first got diagnosed, and thanks to Joel, he was around to help me. But once I could take a step back, I put it into terms of a project. And I said, okay, I need to answer a few questions. Who, what, where, why? The who and the why was who's on my team. Who, and like I built out a roster, so to speak. And that roster could be like I would do a project. Who do I need from the different areas? And it could be comprised of people you already have on your team. Maybe you're already seeing a cardiologist or a pulmonologist or an endocrinologist. Maybe you're seeing those people already, or a gastroenterology person. But now you've got these other people on your team, oncologists and such. And now you've got these teams, but why do I need them? And you need to understand that I may not need a cardiologist now, but if I'm on a drug, I might have a side effect that it just recently happened to me. Scan came back, enlarged heart. I already have a cardiologist on my team. Boom, I'm in for an echo right away. I don't have to wait for that. So building out that team is very important for advocacy. And then you have to, why are they on my team? And who is my core team? Who am I calling first if something happens? So that's very important. The other thing that's answering the who and the why are they on your team. The one is being clear, focused on your goal. What your goal starts out at the beginning and along your journey may change. Like mine is to stay on the first line of treatment, like I said, as long as possible as I can. That means managing those side effects, don't jumping off treatment, working with my oncologist and my specialty doctors to say, what can I do with this side effect if it's not a high grade one, that I can treat it, maybe pause the treatment and come back on. That's what I've done twice, and that's worked for me. That may not work for everybody, but knowing that you advocating with your doctors to say, this is my goal. Because they have a different goal. You go home to your family and you want to go home to your family. So you want to make sure that you're goal driven for yourself. And then the other is the where. The where could be two different things. It could be, where do I have to travel? You can take it as that. Do I have to travel for treatments? Can I reduce my travel? Or where do I go to get information? Because you may not necessarily always have all the answers, but there's so many resources out there. So what I've done with being on these communities and the various symposiums I've attended and such is compiled, like, where do I go when if I can't go to my team? Am I turning to like clinical trials? Am I turning to research? Am I turning to NIH? Am I turning to the NCCN guidelines? And there's a whole host of others to build out that picture to help me navigate the advocacy. And I conclude that why it's so important. I truly believe it impacts outcomes. It puts you in that driver's seat, the captain's chair, whatever you want to say, because nobody tells your story better than you do. No, and you need to tell that story to all these people on your roster, so to speak, because they aren't talking. They may read my chart, but they necessarily aren't talking unless you specifically ask them to. And even then they may not. So when you talk about who's responsible, it's you're responsible, nobody else, because you have to make sure that you are navigating your ship along with this team. And then it's all end out, like, I think of it as you're navigating like three big pieces of pie, right? I think of it as a piece of pie chunked into thirds. One is healthcare, and that could be the radiology places you go. It could be the hospitals. It could be your doctors. And then you've got insurance. And then you've got pharma, which could be handling your specialty meds. Now, each of those could have their own branches, but those are the three big pieces of pie that I drew on my whiteboard and said, okay, here's what I'm navigating. How am I navigating these? Because they all are their own separate beasts.
Are you by any chance a consultant?
I am.
Michelle, I'm going to ask you a question that's going to lead to a question to Stephanie. My understanding is palliative care is not offered to the degree it is offered in Chicago, for example, where I'm at. And then, is that a correct statement?
For me?
Yeah.
Yeah, exactly. So when you talk about your palliative care down here in South Florida, it is fragmented. In the hospital system that I am in, I'd have to go to Tampa, where I see my specialist, and go to their specialty. Or down here, my health system has it's outsourced to another company. So luckily, I haven't needed it. If I had to, I would have to invoke up in Tampa, go up there.
So my question for you, Stephanie, is we talk about palliative care and how important it is, but sometimes we get blank stares when people don't have palliative care offered in their hospital, or it's outsourced, or it's just not very good. And so I didn't give you this question in advance, so it's a hard one, but any things that patients and caregivers can do to help minimize that issue?
Yeah, and that is a really real problem. And I recognize that practicing at a very resource-rich area with where I practice. And I think, as Michelle experienced, a lot of patients only get really robust palliative care like within their health system if they're in like a bigger city or connected to an academic health center. So if you don't have that, what do you do? I will say my team, and I believe most other big academic centers, are very happy to provide palliative care to patients that do not get their oncology care with us. And my team, our really requirement is that we meet the patient in person for that first visit. So unfortunately, that might involve a long drive to come meet us. But we are very open, and thankfully, I think legislation has allowed us to do a ton of telehealth. And I actually started at my hospital in 2019. And so really saw the evolution of telehealth, and it changed the game for us, and I think for a lot of our patients. So I guess I would encourage you to try to reach out to a big academic center, even if it means making a long drive once. But in my experience, most palliative care teams are open to seeing patients that get their oncology care elsewhere. And hopefully they can use telehealth to work with you closely, even if you're geographically far away.
Great answer. We'll be back to you in a second. Janelle, Michelle talked a little bit about how to handle the issue of captain of the ship across different disciplines, primarily within the same hospital. Janelle, can you answer that question with regards to multi-hospitals, when you're dealing with multi-hospitals and keeping them all in the same direction?
Yeah, I'm gonna do this just with an example. My cancer care is through a local clinic here in Kansas. And back in August on a Friday, I went in to get results for my CT scan, and my doctor said, "Hey, Janelle, this doesn't look good." So I had continued progression where it moved to my liver and then to my brain. And he said, "This is the point where I want to offer you a second opinion." So we talked a little bit, and I asked about Dr. Hommers, and he's like, "How do you know Dr. Hommers? Oh, that's fantastic." He worked with him for his residency, and Dr. Hommers had also done his letter of recommendation to work at MD Anderson. So he said, "Oh my goodness, I haven't talked to him forever. I'm going to call him right now. That's a great idea." And then it's only a 5-hour drive for me to go down there. So I also, after that time, called Joel and said, "Hey, I'm going to go down and see Dr. Hommers next week." And Joel also sent a note saying, "Hey, Janelle's coming your way." And the following Monday was a holiday. And the next Tuesday, I was contacted by UTSW to get set up. They were fantastic as far as working with me just continually. I think we talked daily about getting all of my records, because my records were at a whole bunch. All my CT scans were done in different places in Wichita. So they worked with me, and my appointment was the next Wednesday. So within 10 days, I was seeing Dr. Hommers. Had a meeting with him, and he said, "Hey, no clinical trials for you. And I agree with what your oncologist has for you next." The thing that I wouldn't have done before I learned to advocate for myself was something that I did know to do this time. And that was, "Hey, Dr. Hommers, are you going to be sending a note to my doctor? Or how is it that information's going to get to him?" And he said, "Nope, I'm actually going to hand it to you right now." And I said, "Okay, great." So he handed me the note. And then I was meeting with my doctor 2.5 weeks later. So if I hadn't asked that, in 2.5 weeks, I would have gone to my oncologist and said, "Hey, here's what Dr. Hommers said." And then we would have started to get the ball rolling on the specialty pharmacy to put me on my TKI. And coincidentally, the next day I was going on vacation, right? Because I asked that simple question, the next day I put a little my chart in. I took a screenshot of Dr. Hommers' note that he handed me. And I said, "Hey, Dr. Moore," he's my oncologist, he's fantastic. I said, "Here's what Dr. Hommers said. He agrees with Lenvimo everolimus. Let me know what we need to do to get going." That afternoon, it was in the specialty pharmacy. And then I called the specialty pharmacy, and I'm like, "Hey, I noticed that I got approved for this. I just want to make sure that I get this ordered," because my goal was get the medication ordered and have it in my possession before I left on vacation. Because if I hadn't done that, then I'm another 10 days while I'm on vacation not getting treated. So it came the day before my follow-up appointment, which was the day before vacation. And my doctor just went through and said, "Okay, here's what you need to know. Here's what side effects, what questions do you have? And you're ready to go the day you come back from vacation." So my point being is, it doesn't have to be complicated. Sometimes it's just asking the question, "When will I hear from you? Are you going to contact my doctor?" And just getting clarification so that you can bridge those gaps when you need to.
No, what a great answer. And I'm going to just distill that into just a couple points. Don't assume the coordination is occurring between hospitals. Let's assume the opposite. And that's another takeaway. No matter how good these doctors are, unless you are the advocate taking charge and making sure there's close coordination between the hospitals or even among the hospitals, you got to do it yourself. So that's a great answer. Michelle, one of the questions we get in Facebook community, and I think more than one of us may have thoughts here, but when is the right time to get second and or third opinions? Because once again, this goes to advocacy. It's advocating for yourself. And so many times we hear this story, "I trust my doctor. I don't want to offend my doctor. I have faith in my doctor." What's your view? And I'm probably going to go to Janelle, and
Yeah.
I'll probably give my opinion on this one. What's your opinion when you get that second, third opinion?
That's a good question, because my story is a little bit different. And so I had to start out of the gate with opinions because of where I'm located. There are no RCC specialists. So I figured, hey, once I knew it was in my pancreas, I thought that organ could be yanked out. Yeah, nope, can't be. So I went to where I had my nephrectomy thinking, but that was my first thought. But I was, you're scared, you're looking for that comfort, that specialist going to tell you it's going to be okay. We've got treatments and then you're not going to be fine, but we're going to treat it and go on. My first experience was horrible. It was with an RCSC specialist. I walked out more scared than I went in, but I'm going to bounce back to what Janelle said a little bit. So that was my first opinion. My second opinion was with Dr. Hammers. And so on my journey home from my 5-hour drive, I contacted Joel. Between Joel's help and UTSW, I was in the next week. Records were already being sent. They were being pulled by the time I got home on that drive. So I already had a plane ticket out to see Dr. Hammers, saw Dr. Hammers in night and day. So I said, that's the treatment we want to go with. He explained it. He explained side effects, how to stay on treatment, went through every detail. I walked out of there, like Janelle said, with where do I go next? And because I am local, they can't treat you across state lines, obviously, unless I want to fly there. But I had in my hand that second opinion and I felt much better. So at the beginning, go for a second opinion. Then mine turned into, I got to get treated locally. So I got 2 other opinions in Southwest Florida from specialists in the Tampa area. And again, you're always going to find out when you get opinions, 2nd, 3rd, 4th, 5th, no matter how many you get, they may not all agree. They may not be, there's so many treatment paths. So of my 3rd and 4th opinions, I had one of them that agreed with the second opinion, which was Dr. Hammers. And I was happy with that. We decided to do treatment. And before you know it, 5 months later, after hunting down opinions and second opinion, 3rd opinion, 4th opinions, I was on my way to treatment. So that's a long answer because I say anywhere along the journey, you should get a second opinion if you don't feel comfortable with what your goals are and they don't align with what your oncologist or your specialty doctor is saying. Or if something is progressing and you want to make sure before you jump treatments that you get, where should I go to this treatment? A good specialist or doctor is not going to feel bad about that. And then the good thing about having a second or 3rd opinion, as you do have these doctors that you can go back to. So if you're being treated and something happens and you need to switch or get a different opinion, you've already seen them. So you already have them as an ancillary or adjunct part of I go back to my little roster, my team, they're on there. So I say anywhere along your journey. And if you don't feel comfortable, absolutely get one.
Janelle, anything to add there?
I would say for me, what my opinion is that anytime that you're looking at a potential change in treatment, initially also, but when you're looking at a potential change in treatment, and I was incredibly blessed because it is stressful for a patient to say to a doctor, I want a second opinion, just for all the reasons that Joel said. And I was incredibly blessed where my doctor did that for me. He's like, all right, this is the time we need to have a second opinion. I wish all oncologists would do that for their patients because that just took a huge amount of stress off of me. And so now what we've decided going forward is that if I need to change treatment, I go back to Dr. Hammers. We look at clinical trials. We just check everything over. Hopefully I don't need to change for a really long time. I'm hoping to stay on this for 30 years. But eventually when that happens, that's when I'll go back for another second opinion.
Or the next treatment is a cure.
That's right. That would be lovely.
I am not going to repeat what you just said because your answer to the question would be the same as mine. Next, aggravating topic. Michelle, Janelle, Joel, Brian, raise your hand if you've ever had insurance companies say no to the initial recommendation for medications or treatment.
Oh, I have not on treatment.
And ultimately, ultimately, did you get the medications and or treatment you wanted?
Yes.
Michelle?
So mine was go ahead.
Mine wasn't my Devo Yervoy. Mine was the Repatha that wanted to treat my lipids, but because it interfered with immunotherapy, so they tied together. So it was a fight. Yes.
But you fought. The point is,
yes.
Here's the takeaway. When an insurance company says no, don't sit back and take it as the answer if your doctor thinks it's the right decision to have a certain treatment or certain medications. Peer-to-peer reviews are critically important, but you calling the insurance company and pleading your case and threatening to expose their lack of accommodating to keep you alive could scare them. I'd say in 80% of the time I've seen when insurance companies initially say no, if the patient fights it, they're ultimately going to get what they want. The problem is patients don't know that they're supposed to fight it. They don't know that they have to. They don't know that a doctor or a non-doctor in India is making recommendations or mandates based on not a clear understanding of the medical case. And I guess Brian or Stephanie, but you've got to fight the insurance companies. It's unfortunately part of the battle. And if you're not doing that, you are not advocating. Maybe disagree, agree.
I agree with that. And I think it's also because where I've had to advocate, one was on a PET scan, so I'm not going to repeat that. But the peer-to-peer, doing a peer-to-peer is faster than an appeal. So if you call the insurance company and say, I want a peer-to-peer, and the doctor calls the insurance company to say, I want a peer-to-peer, but also on getting the bills paid. So that's where I've had a lot of issues is just like they'll deny a bill and it's, why are you denying this? And it's hard to get that information. And so one other thing that I would say that really helped me in this case is if you have, and it would help in the case of getting scans and treatment approved, if your insurance is through work, you should talk to your HR group because a lot of times in those cases, there are navigators for people who have cancer and they can assign you a person that helps you to navigate through that. So I think that's just another nugget for folks to help them on their way.
Michelle?
Yeah, I agree with Janelle said, because that is true, because I've used the navigation from, I carry insurance through my husband's. I have definitely had to use that. I've also had to call the drug company, and the drug company, they have areas that maybe people don't know. There's patient support groups once you're on the drug, and then there's also groups within the company to help you navigate that insurance process. So many people don't know that either. So if you get in touch with a company, mine happened to be with Repatha, like I said, and got them to work. So I got my doctor's office, I got the drug company, and then I got the insurance pre-authorization team on. And boom, next day it was approved.
So
first it was denied.
And I'm guessing 50 to 60% of patients would stop it at the denial stage and not fight.
Yeah.
That's something
Absolutely. Or yeah. And the other thing is once you do, because you're dealing with specialty pharmacies sometimes at that point. So not only got the insurance and then the specialty pharmacies, they've got competing goals and objectives. So you have to make sure once it even is approved is not only navigating, so you get it approved after that fight or championing your case through, is now it's sitting there and it's now sitting in the minutia, and people don't know this. It goes to somebody's desk that gets entered and blah, blah, blah. You have to stay on constantly calling them as well, because you're like, okay, I won, I got, and it's going to be approved. And then you're like wondering where it's at. You wonder where it's at. And then you call them, you're like, oh, we're waiting for an updated something from your doctor or an update from somewhere. So there's always this waiting and nobody's talking to each other. So even though you do make it through the fight and get it approved, you still have to stay on top of them, like calling them every day. Where is it at? What status is it? And things like that, because they're not going, it's just going to be in somebody's queue and they may or may not know the importance, or I don't want to say that they don't care. Your journey is your own to push through. So
Stephanie, I never like to ask a question I don't know the answer to or know that you know the answer to, but are you involved in the insurance fighting, the peer-to-peer reviews at all? What's your perspective on that?
Yeah, I think where this impacts my realm is insurance companies are very picky about what opioids they like patients to take and are very picky about quantities. And it's really unfortunate that it's at a kind of a big level of Aetna, Blue Cross, Medicare, but it's also even at a Walgreens of just, I'm not comfortable giving you a fentanyl patch. And I think there's so much, I could do a whole spiel about the stigma around pain medication, but it's really unfortunate that a lot of patients feel a lot of judgment from pharmacy and from healthcare professionals for taking opioids when they're crucial to them having any quality of life. I think what others have shared is that when an insurance company says no to a certain pain medication or other medication for symptom management, I've even heard of like denials for Zofran, which is wild. But if you ask your team to, hey, can you complain about this to the insurance company? 75% of the time we can get it covered. Being at the sticky wheel or whatever the expression is, there is merit in that. And I think another takeaway is I've often had patients go to a pharmacy to pick things up and the Walgreens says, oh, insurance doesn't cover it, or it's $6,000. We'll let your doctor know not to talk poorly about our local pharmacists, but please do not take their word that they will reach out to us. Please directly reach out to us, because I've had a million times patients like, oh, the pharmacy said they were going to call you. This was 2 weeks ago. What do you mean you never heard from them? We never heard from them. Please reach out. Let us call your insurance company because there is value. It is effective to call them, as others have shared.
Brian, anything to add on that?
No, I think that was wonderful. Everybody touched on all the points I was going to make too.
Great. Stephanie, I'm going to turn it over to you.
Joel,
Yes.
one more thing where
Sure.
Stephanie said something that kind of jogged my, is because we're dealing with pharma and insurance, and the drug that I'm on, and a lot of people are on Opdivo, it's covered under a different part of your insurance. And then if you go on a TKI, it now switches to your specialty pharmacy. I didn't know, I only know that because when I had to go on the Repatha for my lipids, that kicked over to my specialty pharmacy. So I'm getting, like Stephanie said, I'm getting calls from CVS saying, oh, it's denied or whatever. We reached out to your pharmacy. I'm like, oh, okay. So not knowing anything about that, oh, this is a specialty pharmacy drug that I had to, so that was a whole nother thing, is knowing your policy. Like, important for people, you think you got this insurance until you have to use it.
Yeah.
You should know what's covered under your medical, what is specialty pharmacy, because a lot of people didn't know what specialty pharmacy is until they're now in oncology, right? Now you're an oncology patient and you're like, specialty pharmacy, what is that? Know your policy too. That's an important part of the advocacy, is knowing what is written in, what is classified as medical, what is classified as pharmacy. You know?
It's a great point, and I'm still confused by it. I'm dealing with so many, but I will tell you another takeaway. For Cabo, for example, there's the Cabo copay program, but that has a limit. And then, at least in my insurance policy, there's something called Prudent, which backs up Cabo. So it's a backup to the backup, which means I should be paying nothing for it. And people don't ask. It's called Prudent. I don't know how to spell it, but I don't know how many insurance had that in it. But it's, again, by asking and bugging and fighting. And look, who wants to pay an $8,000 copay bill for Cabo? That's ridiculous. By the way, if you notice that I filled the panel with people that are very supportive of advocacy, you're right. So, Stephanie, I want a horror story that you've seen when no one is advocating for a loved one, and then maybe a really good success story when advocacy is working.
Yeah, I think a horror story is someone I know outside of the hospital who had cancer, not kidney cancer, was dealing with symptoms related to the cancer, mainly pain, fatigue, and was on treatment for her cancer, and asked her oncologist, can I get a referral to palliative care? And that oncologist said, oh, does that mean you're ready to stop treatment? And unfortunately, that is not a totally uncommon response, even at sometimes bigger health systems and even among oncologists. Palliative care is seen as a pre-hospice, or the gateway to hospice, or the gateway to stopping treatment. And sometimes, unfortunately, the patient has to be the one to tell an oncologist or a primary care doctor or someone, no, palliative care can follow patients for years. I follow patients that have non-metastatic diseases, and our role is to really be the experts in symptom management. So that patient, fortunately, was able to, because I advocated for her, she actually saw a palliative care team at a different health system, like I mentioned earlier. That would be a horror story. I don't know, Joel, my time. I thought of a couple other kind of examples of it gone bad. Is that okay to share?
Sure. I promised Brian at least 10 minutes to talk about it.
I will not talk more
You're
than
fine.
the most, but I think other more maybe vague, but I certainly have patients who they think they're not doing bad enough to need palliative care. And they think, oh, I only have a little nausea, or I only have a little bit of pain, and so I don't need to see them. And so then by the time they see us, there's a lot of things that my team could have made a difference in months or even years ago. So don't think, oh gosh, I'm not doing bad enough to ask to see palliative care. I think there's a lot of joy in us, for me in my job, and getting to know patients. Honestly, ideally close to a diagnosis if possible. And so we can support them along the way. And then I think also not assuming that palliative care only has opioids to offer. I think sometimes patients, I've heard that, oh, I thought you were just here to give me the morphine. So just, I think, recognizing that we really work hard to only manage patients' symptoms in a way that they're comfortable with. And if for you that's not taking an opioid, we have a lot of other tools in our toolbox. Or we're not just here to help with pain. We want to help with mental health and really, you name it, nausea, poor appetite, fatigue. So I think, yeah, reaching.
I've used you for more than 5 years and didn't do opioids until like year 4. But I heard from some people that insurance company appreciates that stage 4 patients, give them the opioids, let them deal with the pain that they're in. I don't know, I've heard both comments. That's all you do, but it's important to do.
Yeah. And I think I've also had visits with patients where I've prescribed an opioid. Maybe, for example, we use methadone a lot to manage cancer-related pain, which there can be a lot of stigma around methadone as patients are familiar with it for patients with a substance use disorder. But at very different dosing, it can be super helpful for cancer pain. I've had visits with patients. I prescribe it. Seems like they're going to go home and take it. And then I see them 2 weeks later and they say, I couldn't get over the fact that I'm taking methadone like that. What if my family hears? What if my friends hear? And I guess my takeaway maybe for you all is if you have a mental hang up about a certain medication, just tell us. There's nothing we haven't heard before. I tell those people, okay, you don't want to take methadone because you XYZ. We've got other things in our pockets. Or if you worry about, gosh, I in the past maybe struggled with alcohol use. If I need an opioid now, what's that going to do to my past history of alcohol use that's under control of alcohol use disorder? We want to talk to you about those things. We have heard it all. The more upfront you can be about your fears, your worries, the better our relationship will be, and hopefully the better results you'll have.
It took me an awful long time to agree to use Oxy just because of the negative history. But I will tell you, for me, it's a good drug. And what I've heard, again, I don't know the answer to the question, very rarely do stage 4 patients have the issues with oxycodone abuse that oxycodone abusers have, right? You don't see the typical stage 4 cancer patient abusing OxyContin.
Yeah, and if research opioid history much, the medications like oxycodone were developed for patients with cancer. And yeah, anybody is lying if they tell you there is no risk of developing opioid use disorder taking opioid, but it is a difference of why you're taking it. And it's something that, again, we want to talk to you about and want to have open communication about and work with you if you are feeling like you're developing any kind of unhealthy use of an opioid. Here I said we don't just prescribe opioids, and I talked about opioids.
Lots of takeaways there, but the one takeaway that I ask everybody to think about is one of the smartest thing I did is establish a relationship with palliative care pretty much day one. And again, my doctor, who's amazing, is not as concerned about a side effect of my drug that is a progression, and nor should he be. And where you guys come in really helpful is, I give an example. I'm on a drug that causes urine to get orange reddish. I don't know the name of it. You can look it up. But I panicked last night. I've never had blood in my urine before. But if you look at it, one of the clear, obvious side effects is reddish yellow in the urine. That's a side effect of the medication. It's amazing to me where oncologist will say it's too early for palliative care, or even say you're not ready for hospice. And we owe it to ourselves to educate people that palliative care is much more than hospice. And my personal opinion is that that relationship should be developed day one. It can't hurt. And just like somebody earlier mentioned, the fact that it was Michelle, you create a list of different doctors. I have a nephrologist that on my list in case my kidney starts to falter. I've already met with her a couple of times. We have a baseline. We know what's concerning. It's just smart to do and to keep track of them and have that list of them. And I think palliative care should be part of them. Outsourcing of palliative care, it's better than nothing in my opinion, but it's not the same as in-house, typically. Agree.
I'm biased. I work in a system where my oncologists are one office over. If I have a question for Joel's oncologist, I walk 5 steps, and they respect us and involve us very early. So I think, unfortunately, that's not always the case, but I think the more patients advocate for early involvement and slowly shift the culture of palliative care to be considered earlier.
Thanks, Stephanie. I am going to move over, and we will take questions at the end. Brian, now we're going to move over to external advocacy and things that you do. Does it make a difference, and why we should consider it? And then I'll let Janelle just indicate, as a patient who's active in KidneyCAN, just explain her perspective. All yours, Brian.
It looked like Michelle might have wanted to say something real quick. I'm not sure.
Michelle, go quick.
No, I was saying I'm involved in KidneyCAN.
Okay. Oh, Janelle is okay. Thank you. Michelle, a secret. I'm not perfect.
My sister's name is Michelle, so I'm used to that.
Okay.
They rhyme.
We'll do the bad Michelle. Tell us a little bit about KidneyCAN and what we can do and
Sure.
why it makes a difference.
Sure. Thank you for this opportunity, and thank you, Linda and Judy Nicholson. I've known Nick for 8 years or so, and he was one of the first ones who believed in what we were doing. KidneyCAN was formed back in 2017 with other patients. We realized that there was this massive funding gap for research for kidney cancer. The KCA was working along and doing their thing, but there was this niche in Washington. I lived in D.C. on Capitol Hill, had been going up there, and continued to do some work and found out that no one was really talking to Congress about this lack of funding. First couple of meetings, people confused us with kidney disease. It took a while to educate people that kidney cancer is something. We were in the top 10 cancers and just woefully underfunded. Long story short, after dozens of meetings, I was very fortunate to meet with legislative director of Congresswoman Nita Lowey, who's now passed away. She was from Westchester, New York, rose up to be the appropriations chair, and her nephew was diagnosed with kidney cancer. And suddenly I got an email saying, Brian, we need to talk to you about what to do about kidney cancer. Went over to their offices in 2016 and 17, and we were able to ask Congresswoman Lowey if we could get dedicated funding for kidney cancer research. She pulled a political deal with, at the time, Congressman Rodney Frelinghuysen from New Jersey, and they swapped. She wanted kidney cancer, and he wanted a vote for one of his bills, and we got $10 million inserted into the Department of Defense, which is not normally where you see medical research funding. You usually see it over in the labor HHS bills where the National Institutes of Health and others are funded. We still advocate for that funding as well, big numbers in the billions, but we wanted money for kidney cancer. And so in FY17, fiscal year 2017, we got $10 million. And we were ecstatic. And then the question became, what are we going to do? And when I say we do not receive the money whatsoever. There's a Department of Defense agency out in Fort Detrick, Maryland, that manages the money and gives out the money through a grant process. And it's a unique program where it allows consumers or patients and caregivers to be involved in some of the committees that review the grant applications to make sure it's staying focused on what the unmet needs are. That being said, we polled a number of when the first awards were granted in 2017, 2018, there were 22 grants given out of the $10 million, varying dollar figures. We polled the doctors and researchers that got that money. We found out no one knew any of the other 22. Not that they didn't know it intentionally, it's just that's the way sort of grants work. You get your money, you go off into your laboratory or wherever you go to work. So KidneyCAN with some other folks and some partners in pharmaceutical world as well as individuals, we got together and we decided to create a research summit. And so today, this year, we just finished our 7th annual research summit where we bring those grant award winners together. Backing up for a second, after we got the $10 million, we said we got to get some more. And over the next 7 years, we increased that to an annual appropriation of $50 million. And we were, again, ecstatic to have money starting to flow into kidney cancer. And we're researching. Our mission at KidneyCAN is we believe in accelerating cures. And the way we do that is we can drive awareness about kidney cancer. We feel like we can recruit advocates like folks like you all on this call. And those advocates will help us with going and fighting for funding. And that research funding will hopefully lead to cures. And so we keep working on that angle up until January of last year when, lo and behold, a big axe came across this program at the Department of Defense. And it took a 57% cut of the 35 dedicated funding lines for cancer. Kidney was one of those. Kidney cancer was one of those. We got zeroed out. We went from 50 to 0. And I'll try to cut this short here. Really, timing couldn't be better. Literally, the House of Representatives this afternoon voted for appropriations bills, including the Department of Defense. And kidney cancer is getting some money back. We're getting 1.5. We're getting $15 million back. Pray that it goes through the Senate and that the president will sign the bill and we'll have $15 million for this year. And we're going to keep fighting for more. I'll just try to wrap this up because I know there's other things we can talk about, but we try to make it really easy for folks. Advocacy can be scary. External advocacy on Washington, it can be intimidating. But I can't say enough to people, your voice does matter. Believe it or not, in this country, your voice matters. Tip O'Neill in Massachusetts used to say, all politics is local. If you are a patient or caregiver or researcher in a district, and you talk to your congressional office, they listen. And we've been very fortunate that we now have a little army of 650 advocates across the country, and we're hoping for more. We have just completed about 2,280 congressional appointments, both in person and through hybrid, through Zoom. Put a little plug in here in March. We're going to be having our next spring advocacy days, March 9th and 10th. A small group of us will be in Washington with some of those appropriators to meet with them. And then the rest of the folks will be on the phone on Tuesday, the 10th. We set up all the appointments. We have trainings in advance. We have a toolkit. Hopefully some of these other folks who participated with us can share on that. And I'll just sum up by saying, I've seen the power of what we do when you have a patient or a caregiver and you have a researcher or a physician who has received some of this investment in research, and they're out there working in a laboratory, doing whatever they're doing to help move us forward towards cures. It's powerful because you're creating the hope for the patients, and our elected leaders who are responsible for our tax dollars are seeing their investment go to work. And so I just encourage you, if you're nervous or you're not sure if you want to do it, please take a look at our website. We provide a lot of resources there. We'd be happy to work with you and have you join us in Washington, D.C. We got to climb back from hopefully 15 back to 50, and we could use your voices across the country. We just hit a milestone on our last fall advocacy days. We had all 50 states represented for the first time, and it took us a while. We got from 1 or 2 states up to 50, and now our next goal is to get one person from every congressional district in the country, so we can use your voices to join with us in this effort. And just appreciate all those who've joined with us before, and we're here to have you join with us in the future. Thanks, Joel.
And no, fantastic, Brian. And I did not know we got the 15 back or about to, which is incredible. I'm still angry at the fact that they dropped it to 0. Michelle, you participate just briefly, your view of it and how you feel afterwards. And Brian, if you could put in the chat line the link to your association so we can have it, that would be great.
Sure.
Yeah.
Michelle?
Oh, yep. Thanks, Brian. I participated in KidneyCAN, first of all, the spring advocacy days, and then followed with the fall advocacy days. Not scary. Like Brian said, there's tools, there's trainings, there's coaching if you need it. So I would encourage anybody to do it to help our cause. Reason I got involved was why not? I started with why not. And then when I did my first one, I was like, those of us who can should. We are all fighting this. Any dollar that we can get towards our cause. A lot of money goes toward prostate and breast and other cancers. And we need that same focus on kidney cancer if we're going to make some more strides, some more treatments, some more approved drugs or treatments or procedures. The other thing I can say is because, again, down in Florida, I'm going to make it personal. We don't want researchers leaving some of our hospitals. We want to actually attract more. And when we lost that funding, all along goes it was the risk of losing researchers going to different cancer types. It made it personal for me because I want to live as long as possible and I'm healthy enough right now to help. And I figured, why not? And it's a great cause and I'm going to step up. I also stepped up and went to the congressional offices in my district to plead the case. I've also been emailing them post the advocacy days. And then I'm joining KidneyCAN as a team lead for the next advocacy days for the state of Florida in my District 19 down here. I figured, you know what, anybody that you can talk or sit on a Zoom call for half a day, talking and telling your story and asking and telling why it's so important. We do it every day to other people. Why not do it to the people who may be able to help move that bar a little bit further for us? So
look what we have created. Sorry, Michelle. We're at the end of the hour. I'm just going to do closing. First of all, if you have any questions, let us know. And you know how to reach us, I think, outside of this call. This will also be videotaped or audio taped and videotaped. So we know a lot of people read this and participate via Zoom when they can. Closing comments will go the opposite way. Brian.
Just want to say thank you to everybody. Your voice does matter and your voice counts. Michelle, thank you for those comments because it is true. You can make a difference.
Thank you, Brian. Stephanie?
I think I'll just steal what you said earlier, Joel, of that you are the captain of your ship. And I think I feel like I'm a little bit on the outside here because you're all living with this illness and I'm trying to help people. But no, we care about you. I care about you all, but not as much as you care about yourself or as your loved ones care about you. Don't be afraid of stepping on my toes. We're tough. We can handle it. Your doctors are tough. They can handle it. And yeah, just own your story.
Great. Janelle?
I'd just say, just remember that you're not being high maintenance. You're not being a problem patient when you advocate for yourself. You're just doing the things that the system doesn't do well for folks who are in our shoes. Just remember, you shouldn't be afraid to ask the questions and to put the notes into my chart and to connect the different providers together.
That's great. Michelle?
Yes, I agree with everybody said. You're your own best advocate. You know your story best and can advocate the best for yourself. And sometimes advocacy is not advocating to live longer, it's to live better. So if you put that in your mind, you just want the best life that you can live and only you can tell your story the best.
No, that's great. And I would just finish by saying, if you don't advocate for yourself or don't have an advocate today, change it tomorrow, because it's something you can change midstream. So anybody in here, I challenge you that if you can't name the advocate, or you're just relying on the medical team to handle your case, you've got to advocate for yourself. And that, again, can be your loved one or a spouse or whatever, or both the loved one and the spouse. So we are done with our hour. We've finished pretty much on time. Thank you, Linda. Thank you for having us. Again, every one of us is reachable pretty easily, especially yours truly. And thank you, Tracy. Thanks for the compliments. Again, this is a subject that's not covered a lot, and I think it needs to be. So I think it warranted the hour that we gave it. So with that, health and happiness, I hope and pray that you guys are doing well, and hope to see you at my next open patient forum in a couple weeks. I will talk to you guys later.